Okay, I'll start. Right, here we are in our first session with Isaac. I think, yes, it's always hard to know if I'm actually on or not. I believe I am. So you've already scored 10 points for the special prize just coming along. So that'll happen every time. So we also want to thank AbbVie for sponsoring this particular session. And if you can, at the bottom of your screen, there's attendees and sponsors, and just have a look there. There's some information in there, and I think there's prizes and things, so it's worth having a look. So I think before I start and introduce Isaac, I'm asked to just remind everyone that we've got health pathways, and there is a health pathways that relates to this session, and it's such a useful resource. I think most of us know and use it regularly, but it really is such a great resource, and it's designed for our context and our community, and there's so much useful information. I use it regularly. It's wonderful. So I would like to introduce Isaac. Isaac Marshall completed his dual specialty training in general paediatrics. I've got a little different spiel than that one there, but I'll read that one because I think it's a better one. Medicine, arts and bioethics. Isaac Marshall completed dual specialty physician training in general paediatric and neonatology in 2012 before joining Barwon Health Paediatric Team in 2013. And I think Isaac's very well known to all of us in GP land. He since 2015, he's been part of the Children's Services Management Team within the Barwon Health, and he's an active member in the statewide neonatal committees. His interests include regional development of neonatal care, clinical teaching and junior staff mentorship, and a fledgling interest in functional echocardiography. He also is an irrational passion for committing his physical well-being to 2 wooden planks, gaining an alarming speed with gravity while hurtling down snow-covered hills trying to keep up with his 2 daughters. I think we're all looking forward to getting to the snow this year, aren't we, after missing last year? So it's my great pleasure to put it over to Isaac to talk about ADHD. Thank you, Isaac.
Yeah. Thanks very much, and thanks for that generous bio, which I think I wrote 18 months ago when I had energy before COVID. But it's nice to be reminded of how inspired I was at that time. I'm presuming everyone can hear me because someone will yell out or something will start flashing if not. But thanks very much for the invitation to come along and talk with you all this morning. And I haven't quite got the face-to-face experience we always look forward to being able to put faces to the names of all the referrals and letters that we send back and forth, but it will happen eventually. A bit unusually for someone, I guess, with the combination of Gen Peds and neonates to be asked to talk about ADHD, but perhaps not that unusual because I always tell my neonatal colleagues when they give me a bit of ribbing about the fact I spend my life giving out illegal street drugs now that ADHD is the most common complication of being born premature. So it is a combination of passions. Just before I begin, I'd like to acknowledge the traditional custodians of the land on which I'm sitting and working today, which is the Wadawurrung people of the Kulin Nation, and I pay my respect to their elders, both past and present, and thank them for their ongoing care and leadership of the country which I live on. In terms of conflicts of interest, I have no financial conflicts. I will openly admit that there are too many patients and too little time, as we all have. And so I bring a little bit of moral distress because every referral that we can't see, and when you can read between the lines of a passionate GP who can just see that all this kid needs is a 1 hour consult, and we're changing their educational outcomes for the next year, 2 years, or 5 years, it's very frustrating to not be able to see all those patients in the daylight hours we have. And so today's going to be an undisguised plug for shared care, and it is high time that we get ADHD purely out of the domains of the pediatric rooms and share the love. So today, if I keep on time, I'm hoping to get through these sort of 3 components. One, just some essential tools, what to know about for people that have got to know everything about everything. And then specifically what you can do for your patient in the primary care setting and how you can work with your paediatrician and, as the big kid grows up, your psychiatrist to help the patient in front of you. And then hopefully a bit of an inspiration to choose your own adventure and join us in co-managing these patients. So in terms of what I think we can and can't get through today, we'll go through a little bit of, how we decide what ADHD is and a little bit of just underlying just how common it is out there, how prevalent it is. I don't think I need to tell too many people in a medical audience why ADHD matters, but we're often tempted to jump into these launches over dinner parties for those that need a little bit of nudging towards the fact that this is actually a recognised disorder, has serious impacts on people's lives and functioning. We'll run over a refresher for the medication, what medications are, but they don't move too quickly. But there's been a couple of changes of late and a little bit on the behavioural and environmental modifications. Not going to get into any of the interesting things that might be happening up in the cortex because I won't pretend to understand exactly what's happening, and I'm terribly pragmatic at the end of the day. So I thought I'd start with, in terms of what can I, or how can I help as a GP? So isn't this just an area that the specialists do, the paediatricians do? And I'm going to fill up this right-hand side of the screen with lots of things that we can be doing. I started with being in their corner, and I made a very quick allusion to the fact that there's a lot of community misunderstanding about ADHD, and the last thing these kids and these families need is for us on the practitioner side of it to be bringing unnecessary biases to the table. So, first and foremost, we can all be advocates for these patients and their families. This is huge, and this is what you guys do every day, but that trying to spot the wheat from the chaff. And I even sort of highlighted that huge. We'll come to numbers about how common ADHD is, but we all know behavioural issues or parental concerns or teacher concerns or nursing concerns are far more common than the population of kids that are going to turn out to have ADHD. And it takes time to triage and pick all that stuff out, and there's only so many people that can do that. And so the trying to separate what your sense of really, is this at the extent that this is actually at the ADHD spectrum and not just other things that are presenting with behavioural challenges or difficulty containing child behaviour at home. We really rely on the ability to triage that out, because someone's got to do that, and if we're using up our time doing that, that's fine, but it means that there's going to be a waiting list of unseen morbidity waiting out in the community for access to an appointment. Just a little plug that we gave before. So in terms of helping separating the weed out, again, a lot of work went into development of health pathways, and I'll give a shout out to my colleague Mike Forrester, who led this work quite a few years ago, and I know we're all involved with writing different pathways, but we're fully aware that you guys have got to know everything about everything. So it's not fair to do that, but we've done what we can to try to sort of flag out some initial red flags that might increase index of suspicion or direct you to other resources or other possible diagnoses that help, and then sort of straighten up referrals, I guess, or pick the right referrals. Lots of education and explanation to parents and myth busting, and we all know the family GP has a lot of trust. They won't see us as much as they'll see you. They've seen you for other reasons. You've built up the trust, and so if you can jump in the corner with the education and explanation, myth busting, you're a trusted source of reliable information. When to refer and who to refer to. I'm not even going to pretend to have an answer to this in terms of overcoming access issues. And sure, I can refer to a paediatrician, but which paediatrician is going to accept them? If anyone's got an answer for that in the next 40 minutes, throw it up in the chat. So I'll just put it up like we mentioned it. Comorbidities we'll come back to is huge in ADHD. So when we've got a kid that genuinely does have ADHD, high index of suspicion for other things going on, particularly anxiety. The oppositional defiant disorder and conduct disorders all get a lot of press, but you know, things like anxiety sometimes can sort of masquerade a bit or present in a different way than what we might typically expect. Certainly, primary care have a responsibility for keeping an eye out for adverse effects of medications if you're seeing the children incidentally for other reasons. We're often only seeing these kids every 6 months because that's the sort of length of time that's been put down for prescription. And unless there's other sort of issues that we're managing that require more regular follow-up, that's a bit of a gap. Again, it's all about access to communications to relaying concerns, and you guys might spot something of concern before the parents even do. We're going to come back to co-prescribing. Everyone that's listening in can potentially prescribe street drugs or Schedule 8 drugs, and I don't mean to be dismissive like that, but I think it's busy and it's just getting the message out of it takes a little bit of time to sign up for a permit, but it's mainly about letting you guys know where you can go. It's all online now. And it's about, sort of opening up that dialogue with your paediatrician. The parents and the families that I have in co-share or in shared care arrangements really appreciate it, actually. I haven't had anyone drop back out and just stick with one or the other. Is a big issue that we have limited control over at the specialty end. And we'll come back to that in a little bit, but it's particularly concerning that there's a huge drop-off in engagement with the medical system prescribing for patients with ADHD and stimulant prescription rates in particular, and an ongoing relationship with a primary care physician or general practitioner offers an opportunity to safeguard against that. And then finally, there's no patients affected in isolation, and ADHD is very challenging for the rest of the family as well. It just adds an extra element of parental challenge on top of all the guilt and anxiety parents live with by default, and also has impact on unaffected siblings. So it's a very, by its nature, attention-seeking disorder that takes a lot of attention day in, day out, hour in, hour out, minute in, minute out. We're always kind of on the lookout for the quietly well-behaved sibling that's sort of just fading into the background and is aware that mum and dad are getting exhausted with kid number A and just asking out how that's affecting them. So plenty of busyness there. How prevalent is ADHD? So it's estimated around 5%. Now, this isn't a disorder that has an on-off test. So it's a little bit in the eye of the beholder. And we don't have specific figures for Australia, but we have no reason to believe that we're going to be any different to the rest of the world. And it isn't just a Western or a developed country disorder. It seems to be about that 1 in 20 across the world. It's the most common condition seen by paediatricians in Australia today. And when I say today, I'm quoting actually a study that's now 22, 23 years old by Peter Houston, who was in one of the Geelong paediatricians. Would it still be 18%? It certainly wouldn't have gone backwards. And the only way it could have is that it possibly has gone up. And it's only that it's probably competing for consult room with autism in 2021. But we see a lot of children. I wouldn't have a day in the rooms that I'm not seeing at least several children with ADHD. And therefore, given it's so prevalent, it must be seen commonly by GPs. And it may not be the reason that the kids are presenting, but 1 in 20 kids that you see over a week are going to have ADHD diagnosed or not. Just throwing this slide up just to give a bit of an indication that our prescribing rates are trending up. I mean, this data is now 5 years old in terms of the latest data. But if we just see that thick black line, which I don't think I can sort of signal from where I'm standing, but the thick black line, sort of an average Australian rate, has slowly crept up. So we're prescribing more ADHD medications. This isn't meant to be a Geelong-centric talk, and I'll zoom out to the whole Western sphere and we can all take our responsibility, but there is only one dark blue, very high rate of prescribing that really comes up in the Victorian map, and that's Geelong. And if you zoom out there a little bit, you can see it's a bit hard to sort of bring in the whole Western Victoria on that map. But Geelong has to own the fact that we are the highest in prescribing rate in Victoria. So that's a very busy slide with lots of dots. But this is Geelong sitting as that big dot up here. And if you look down that second column on the right-hand side, the only sort of presence in the top 10 is Geelong. So we certainly have a very high, I don't think we're giving out more Ritalin to our kids or they're needing more prescriptions than anyone else, but it just goes to say that, it goes to the case that we have a very high prevalence, or especially high prevalence locally. This slide doesn't narrow down particularly on Geelong, but if you look up along the top, it's sort of breaking down the population into major cities, inner regional and outer regional, and then further subdivides into socioeconomic status. And perhaps not totally unexpectedly, there's a higher rate of prescription of ADHD represented or associated with lower socioeconomic status. And we don't have time really to go into today to speculate too much, but there's certainly a lot of understanding from the pediatric point of view that there's certainly likely generational inheritance of loss, and ADHD is a strongly inheritable condition. So it's debatable about does the street you live in cause the ADHD? Well, possibly the street you live in is secondary to unrecognised or undertreated ADHD or undersupported that might have even run in generations. But like I said, I wasn't going to launch into that, and I've already given it a minute and a half. That's a conversation you can take up over lunch. So this is the ADHD that you bear down and try to get through the 10 or 15-minute consult while you try to figure out which pediatrician you can get this kid out and still have your room somewhat intact. This one can hide a little bit more, which is the more inattention predominant. But it's when you really boil down, it's pretty unusual not to have a little bit of symptoms of each. And these are the two classic sort of phenotypes or presentations that we try to categorize one kid into another. But even the inattention predominant kids, which is I must admit, even when I sort of write an issue list, I'll signal those by specifying that they're inattention predominant, just so everyone knows, look, this is genuine. I'm not just treating daydreaming. But even those kids, when you really boil it down to it, are sometimes prone to a little bit of fidgeting or a little bit of restless legs. They often are the kids that are very well regulated with themselves and have taken on what expected behaviour, and so they're often hiding and they're not jumping out of their seats or yelling out impulsively, but they do often have symptoms of both. The symptoms on the left jump out at all of us, and really it's a spectrum thing, and the kids we're worried about is when we see kids that are really up the upper end in terms of arguing and fighting and bossing and breaking rules and jumping all over the shop and are terribly impulsive and always on the go and can't stop to sit through dinner, can't stop to sit through their favourite movie. Those sort of kids jump out. So it's just a bit of a flag that the ones on the right are harder to tease out, and I find it difficult as well. Everyone can memorise this page in the next 5 minutes, but just to flag, the DSM criteria would probably be relatively familiar, but we're wanting lots of symptoms in each area. So the 6 symptoms of inattention at least, and hyperactivity. That inappropriate developmental level is very key. And that helps with trying to organise even at the primary referral stage. All kids age 3 have ADH. They're probably not disordered. They might be causing disorder, but we all are aware that attention spans, focus, concentration, levels of physical hyperactivity, very age dependent. And so one way of sort of just asking yourself is, and probably one of the reasons we see a lot of referrals at the start of school is that suddenly you're doing a sort of a lining up from 0 to 100 in the classroom, and the teachers can usually spot the ball of activity in front of them, and it jumps out. So one question to ask yourself is this 6-year-old presenting like a 3-year-old? A 3-year-old's allowed to present like a 3-year-old in terms of all those symptoms. But is this a 6-year-old that looks like a 3-year-old for all intents and purposes? And we certainly see these amazing sort of sibling examples of a 7-year-old, everywhere, and the 4-year-old sitting quietly, just entertaining themselves or following the conversation. So I won't go through all the symptoms there. We can read those in your own time. Present before 12 years of age. This is really key. The other thing, which I'll come to in another slide, is that it's going right across this young person's life. So just having symptoms in one particular field usually points to something else. So the kid who's absolutely angelic at home, where they should feel safe and more secure, but is playing up at school, is usually telling us something else. Are they having difficulty at school? Are they particularly anxious at school and getting bullied, etc.? And vice versa. The kid that you can really nail down an opinion from a teacher or from activities supervisors that there's no concerns about their concentration and focus, etc. But then the history you're getting in the room is of a lot of parental difficulties with containing behaviour, etc. It might be pointing to something else that's happening more on the home front and doesn't carry over to affect their functioning in the classroom. And the last bit I put really bold is that ADHD needs that D. It needs the disorder. And again, the disorder, the extent of disorder you need is a bit in the eye of the beholder. And I imagine I actually probably a bit of a dove on disorder, especially. So one of the things I rally against a bit is the smart kid with ADHD doesn't need medication or doesn't need treatment. And I think ADHD is nothing to do with IQ, and I'd say their IQ might be compensating for them, and the fact that they're getting through their schoolwork and therefore don't need medication just per se is something we possibly should challenge, because we don't know the amount of mental effort and that's going on inside for that child to maintain that level of functioning. But of course, that's going to be an ongoing conversation and weighing up pros and cons in terms of therapy. So it's a bit of a vibe definition, really. We said there's no on-off test. You're getting symptoms and history from the patient, depending on their age, and asking appropriate questions because of that. Certainly parents, teachers are very busy. We ask so much of teachers. We ask them to be all over every condition. So one of the advantages of a simple questionnaire, though it takes them a little bit of time, is really try to sort of target on the symptoms we care about. We don't care about the kids being naughty. We care about their focus and getting through tasks. So we're trying to get past, swearing is not ADHD. Impulsive yelling out, maybe. Integration aids are fantastic because they've taken the pressure off the sort of leading the room that a teacher has to do, and can often observe the kids without being noticed. And some of these kids have integration aids because of lower cognitive ability, and you can get a great history in terms of the ability to focus and concentrate. And then other allied health professionals that some of the patients are involved with, such as speech therapists, occupational therapists, etc., you can often get feedback about how their concentration is going there. You can even get it from their swimming coach, which I find fantastic. So you can, if you're ever sitting at a pool, just watch what kids are doing at the other end while the teachers or the instructors give you out instructions, and you've got the full spectrum of concentration and focus and hyperactivity. I have to be very conscious of my bias, so I hold hammer, and people have often gone through a few rungs by the time they've got to me. I have to take that on board and saying, well, there's been sufficient concern that they've got all the way to me, but I also have to be aware that that's going to bias my interpretation of their history and symptoms. So we're certainly looking for multi-source feedback. There's formal assessments out there, and a lot of you would have come across Connors. It's probably the main one. I give a very abbreviated version of a Connors. We're all busy, and you can usually get a sense of a constellation of symptoms by the time I'm seeing the patient, and you can run through some questionnaires and you're looking at the kid at the same time. And it's terribly helpful for the parents to have turned up with feedback already from the teacher. That often have a few key adjectives and verbs hidden in amongst the paragraphs that are flagging particular concerns. One thing that does come up is cognitive assessments and the role for that, and we'll come back to this a little bit later on. But there's been a shift in that, certainly in the time I've been in paediatrics, and now we know that the incidence of or the prevalence of ADHD, and therefore the probability, pretest probability, when this child turns up to your room, is that it's more likely to be ADHD than an intellectual disability. A lot of that's in your sense from your presentation, though, and the context. But we'll often start a trial of medical therapy before we can get a very expensive IQ test. But it's important to always consider, is this actually lower cognitive ability presenting as inattention focus, concentration difficulties, frustration with not being able to do it, all of which are going to be, the symptom overlay is exactly the same if you can't do what the teacher's asking of you, and that's being under-recognised. So you've just got to keep that in the back of the mind, but practically, most kids set off down the stimulant therapy trial, at least while we're thinking about trying to access IQ. How do I use a little bit of questionnaire? I do use it as a way of verifying. So I do work in a silo. I work in one little room on Ryrie Street in Geelong. I'm often asking about teachers, what they thought of a teacher in Bannockburn. And I'm trying to correlate that with the parental report that's been given to me and the GP concerns that have been raised. So it is one way of getting everyone on the same page, more so than being diagnostic, that if you get so many 4 out of 5s or 5 out of 5s, I'm gonna give you a diagnosis. That's baseline pre-therapy. So I think it's good to remind everyone when we're a few years down the track in terms of where things were, if things are going okay, and we're contemplating the ongoing role of stimulant therapy, and getting past misconceptions. So I sort of flagged I've really specific symptoms I want of observers, in particular teachers. And so it really targets down exactly what I want them to provide some feedback from in terms of behaviours. So I don't really care about the swearing for a diagnosis of ADHD. Why does ADHD matter? This is an entire lecture in itself. I'm just conscious of time, so there's a whole raft of different things that sort of spill out over the course of a lifetime. ADHD is a chronic condition. It's lifelong, so it's the way you're built, and nothing we do at the moment is going to rewire that, or there's no magic pill to make it go away. And it's often about controlling symptoms and learning your own functioning. And it's sort of, from the point that I'm playing with, it's certainly the learning and developmental problems that I'm mainly concerned about, so that they're getting the academic start that they can to be an equal footing, and the social start for an equal footing going into adulthood. It's very expensive to miss ADHD, but this was a devastating stat that I keep coming back to, and that half of children with ADHD have no reciprocated friendships, which is almost twice the number of that typical children will report. So, for all that fireworks that you're seeing, these are often kids that are very lonely and don't know why. Right, we're all medical, so I'll touch on the behavioural modifications, etc., so that we know about it, but we're often the only ones with the prescription pad. What can we do in terms of pharmacotherapy? Start with sleep, right? Sleep's another whole lecture, but if you've got the time, so many behavioural issues in children present are actually secondary to inadequate quality/quantity of sleep. So it's the first question I ask with any referral that sort of says anything about behavioural difficulties. I often tell parents that, it sounds like you turn up to a doctor and we're pushing pills. it's not all about the pills. There's so much more that can be done, and we work as a part of a team with all those different people that are contributing to the vibe diagnosis that I mentioned. But we're the only ones with the prescription pad, and that's our responsibility to make sure that any prescribing is done safely and appropriately. So, but also when we look at the evidence, medication is certainly consistently the most effective tool in terms of ADHD symptom control. We already mentioned that the sort of practical approach now is often, if we're at that stage that the young person's functioning is disordered, to start stimulants first. And we'll think carefully about cognitive assessment, whether that's required or not. And again, I'm happy to answer questions on that. But, it's certainly in the state system, there's a huge lineup. Schools are going to naturally be biased towards results on cognitive assessments that are going to provide funding. So unless you're lined up to get an IQ less than 70, it's informative, but not going to be terribly practically change things in terms of funding, access or integration aid funding at school. How old do you have to be before you start? Well, the most common referrals we get are when kids are in the classroom and a teacher affirms background parental concerns. I very unusually start before 6. That's an area of different practice. In terms of medication, I do have a couple of patients who have started 5. My youngest patient ever in my career so far is 4.5. Obviously, the level of disorder needs to be so extreme at that stage that you're really up against the wall and trying anything you can. In terms of pharmacokinetics and dynamics, in terms of effects of the medication, stimulants are a little bit trickier to use the lower you are. They tend to be more adverse effects. The dose range for a therapeutic range tends to be a bit narrower. And you risk sort of losing faith of the family also if any of those things happen. So we tread carefully. A lot of these medications will be familiar to you guys, and so without mentioning any trade names, methylphenidate and dexamphetamine are the most common. Personally, 90% of my patients are on methylphenidate. You just got to pick one of the two. To start, the evidence suggests that positive symptom control is similar. It's just they're slightly different risk profile in particular individuals. And so usually I'm simple. I'll start on one, and if we're getting positives but some negatives we don't like, I'll switch across to the other one, hoping I can retain the positive effects and can avoid the negatives. Both are available now in an extended release formulation, but we have to start the short-acting first to sort of a PBS stipulated practice point to make sure there's no side effects is really the main thing. Just to mention guanfacine. So guanfacine came on the scene about 1.5 years ago, September 2019. Very commonly used in the US for ADHD. Has sort of, started creeping in a little bit. We've had mixed results, I have to say, just sort of informally surveying my colleagues. It acts in a similar way to clonidine in that it tends to be, if anything, I think, a bit more sedating. And ideally, that just on paper is not terribly attractive to me. We're not really trying to... But the best role for this sort of seems to be as a combination in combination therapy with kids that benefit from either methylphenidate or dexamphetamine, but can't tolerate the higher dose they need to get more complete symptom control. So you certainly see kids that are probably on a combination. It would be the most common in my practice at the moment, if any of my kids are still on guanfacine, of being on a sort of moderate dose of methylphenidate plus guanfacine as an add-on. I haven't found it terribly useful yet in isolation, but as I sort of said, it's only been around for 1.5 years, 2 years. We'll accumulate more experience with it and certainly share that with you. You need to start at short-acting. I try to get everyone across to long-acting. I just think it's a better medication in terms of trying to iron out the any side effects. The main one being sort of agitation or anxious with that sort of peak serum effect of short-acting medication. Once you get it a little bit more even, which is the way you and I run, then we can usually get on top of that. Just to be aware, we can't get long-acting, unfortunately, on the PBS prior to 6 years of age. As I said, we're not prescribing too much stimulants before then, in any case. A little bit frustratingly, there's new PBS eligibility that's just sort of snuck in, or maybe it didn't sneak in, but it snuck into me certainly, that is now capping the amount of extended release or total dose that we can get of the methylphenidate and dexamphetamines, which is a little bit challenging because there's not too many patients that need higher doses than the caps that have been set, but there certainly are some. And now, we're in the difficult situation of are those patients and families set up for paying for private prescriptions for what is a chronic condition to get dose they require. That's unfortunately just sort of something we're working through at the moment. I've got a couple of patients, unfortunately, I'm having to juggle a bit and try different things to see if we can avoid eating into their university tuition fees just because of this new cap. Stimulants, great things. Don't we all run on stimulants already? We don't have to Schedule 8 them, but we all are inclined to a little bit of coffee in the morning. They do wonderful things. And essentially, I can run through some of these advantages to parents, but I ultimately tell parents, look, I'm not the parent of your child. I'm sure you'll see great benefits, but that's up for you guys to see. And really, my role is to tell you is to decide two things. One, is this appropriate to even be trialing on your child? And secondly, what could go wrong? What are the possible adverse effects? And you can come back and tell me, because the teachers will go, yes, and you'll probably go, yes. But it's all about this other side of what could possibly go wrong. And I tell people about 5 side effects. I frame it as 3 are common, but less possibly serious. 2 are more serious, but less common. And the top 3 there are the 3 I go through. Pretty much all kids will get some sort of appetite suppression. It's a great diet pill to go on stimulant therapy. The important thing from our point of view is that there's no evidence long-term, or there's no convincing evidence or consistent evidence that there's any impact on growth. But that's the main reason I tell parents I want to see them every 6 months, or they need to see someone every 6 months, is to make sure that the appetite is not getting to the stage of affecting the weight, to the stage that it's affecting the height. But a loss typically of a sort of 500 grams would be par for course in my experience of a primary school child. The kids can get a little bit of headache and nausea when they first start, but that tends to go away in the first week. And it's almost like starting coffee. It feels a little bit weird, and then it feels natural after a few days. So, for what it's worth, we try to get the kids to take the medicine with food. Sleep disturbances, mainly if you forget your medicine and leave it too late in the day. So if we're taking it first thing in the morning and then the short acting in the middle of the day, it's usually worn off. I wonder if there's a cohort of kids that are on the long acting form that they take 7 in the morning and it lasts through to 5 or 6 at night, whether their appetite suppression is finally giving way at that point and they have a huge carb load and therefore can't get to sleep at when they're put down at 6:30 or 7. So that's a bit of teasing out in history. But mainly if you're keeping the medication early in the day, it shouldn't be a problem. The 2 more serious things we keep an eye out for. So some kids definitely get too agitated. And anxiety is a very common comorbidity, and I warn parents that we actually might cause more anxiety or even bring out tics. So it doesn't create tics, but it can unearth tics that are there. A lot of kids with ADHD, though, actually the flip side is, treating their ADHD symptoms can actually help their anxiety. We talked about that sort of unwritten social implications of not finding conversations or butting in when you shouldn't. They may not be as scared to be picked on in the classroom because they can still remember the story they're being asked comprehension questions about 10 minutes later on. So it can work both ways to adequately treat their symptoms. The very serious but extremely rare side effect is I tell parents about hallucinations. And that's the one thing I want people to ring me straight away. We are, of course, going to have follow-up after we start these medications, but they need to jump ahead of the follow-up if there's any concerns about visual or auditory hallucinations. We reassure parents that there's no physiological dependence. So do tell parents that a lot of ADHD is not just about bookwork. So there's lots of other challenges we ask of children on the weekends, etc. That might mean that they could support with the medication. I'm just going to race ahead, but say stimulants do wonderful things. You're much less likely to fail school, much less likely to have major depression, anxiety, and bipolar. There's lots of behavioural modifications that are that we can be working on, and that's mainly about expectations of how ADHD works. There's terrific resources out there about finding out about these things. One really useful one is that website I've just given you at the bottom of that slide, which is the kids info section, or the fact sheets of the RCH have lots of behavioural modifications. Even things like breaking down 3-step commands into simple commands, using the child's name first to get their attention before asking us. And being very aware that the sensory overload can sound a bit wishy-washy, but one of the issues with ADHD is they're just taking in too much from their environment. For instance, when playing class, the sensory that has to be processed is amazing. And what you're really asking children to do is, out of all the visual stimulation, auditory stimulation in those environments, to keep focused on the talking adult at the front of the classroom, that voice and that vision. And one of the sort of understandings of executive functioning in ADHD is all those things are on an equal playing field. So someone dropping a sharpener next to you has the same amount of grab on your attention and focus as the teacher continuing their ramble up the front. And so some kids, that's inherently easier to keep their focus on the teacher, but for kids with ADHD, not so. If you guys have access to the slide, whoever's jumping in there, just tell me to stop talking if you wish. But if you guys have access to the slide, this is a terrific guide that's not just about teachers, it's about parents, it's about us, in terms of different ways of working. And that, little kids with ADHD have to keep moving or they can't really pay attention. And if you ask them to sit straight and concentrate on that, they're concentrating on sitting straight and not concentrating on their maths problem. Brain training doesn't really work. And then the last thing I'll flash forward, apart from being in their corner, admiring the courage that it's taken for families to present with with a kid that might be just misbehaving, and about providing some realistic expectations for ADHD. A 5-year-old kid in a prep class might be just young for their age. That there's lots of positive people out there that have maybe not listened. There's lots of other positive people and models that have ADHD. And there's lots of parents come with ADHD. And Sherlock Holmes, latest Guy Ritchie formulation, if you've ever seen that movie, fantastic perception of everything that's in his environment. And that gives a really good understanding of what an ADHD brain works like. I'm going to this last bit because I have to put this plug in. Co-prescribing and co-sharing. GPs can prescribe methylphenidate, dexamphetamine, lexdexamphetamine. You do need to apply for a permit. The ideal share arrangement would be seeing you guys once a year, us once a year. So they need to see someone every 6 months. But that will fit in with the pediatrician every 12 months. But of course, you can contact the ped for any advice you have about the prescribing or any symptoms in between. And it will just help access on both sides, especially for the kids that have got straightforward ADHD without any other complications. We're aware that a lot of these kids have a more complex behavioural phenotype, and it's probably not appropriate for a primary care fitting. But if you can take notice of those web links, and maybe at that point I'll stop talking and give over to the convener, who I can't see, but might be waving furiously at me.
No, you should be able to see me. Can you see me now?
Yeah. I'll link it. I'll come out of my share screen and be able to play.
Thank you so much, Isaac, for that overview. So, I mean, the thing that really struck me is how common it is. Like, we need to be able to manage it with you, and I think that's such an important message, that let's do this together. And I think it's a win-win. We learn more, We help our patients more, and it's such a common condition for us to manage together. And I think we're seeing a lot more adults asking whether they've got it too. We're seeing that side of it, which obviously this talk's not about, but, you know, it's got missed, and then adults are asking for this diagnosis, which there's a bit of a difficulty in getting that happening as well. And I think GPs are seeing a lot of that. So
I guess why you're pulling a question, I definitely flag that. And you guys will know the family better, but I'm a bit cheeky, and I sometimes nudge the parents, because it is often very insightful to go through the whole diagnostic process with their child and go, I was exactly like this. And then you'll get the next parents that makes that past tense plural present, and will say, well, actually, I'm still like this. And you're right. And it does run in families. And it makes parenting easier if you can diagnose.
Yeah. But, you know, a lot of adults do well on medication as well. But I want to open it up to our questions. So there's lots of questions here. So from Kathy Turner, do you give dietary advice to patients with the ADHD? Would you ever try lifestyle measures first?
Yeah, so to the extent, is that Kathy? Obviously, dietary advice is needle in a haystack. So there will certainly be families that can identify a particular preservative that sets their child off. That's fine. And if they come in, I would never argue against that, because that's their child. They've done that hard work. Do I set off parents who haven't done that a sort of dietary hunt? I don't send them off on dietary hunts. In terms of lifestyle modification, all kids with ADHD would have the lifestyle and behavioural modification, which medication. So it's really time control as well. So some of these kids, fortunately, with their second suspension, that's more time than the kid that had mustering over a couple of years and what else could be doing. So I think it's case by case. But all kids have the behavioural environmental education modifications. Majority of kids will also get therapy, but not all.
Next question. I'm going to whip through them because there's actually quite a lot here. Jan Wisfeld, does high prescribing rates in Geelong lead to better outcomes in Geelong?
We don't know. It's a fantastic city to live. No, it's actually, not to be facetious. So I don't think we have the local data, and it'd be fantastic to have the local data. It was interesting when that survey came out, because there is one interpretation which I didn't go into, is that we are still under prescribing. It's just that Geelong is the least under prescribing in terms of, we think that stimulant therapy is the most effective therapy. We're possibly not still yet at the right rate, but that's a debate for another time.
This question got lots of thumbs up from Jessica Foley. How often do you prescribe melatonin to help with sleep in this patient cohort, and down to what age? Or I guess what's the youngest age you could use melatonin? Yep.
Love melatonin, and I'm very happy personally for any primary care person that contacts me to prescribe it. The main thing with melatonin is talking about all the other sleep hygiene things that need to happen, and that's a very big thing in terms of behavioural modification. And it will not compensate for a chaotic household with 3 other kids and one who's not going to sleep till 11:30. But getting onto melatonin, I think melatonin, in my experience, has been very safe. It's a naturally occurring hormone, so it's more acceptable both to patients, families, and to us. One of the issues is you have to get it compounded at a compound pharmacy if you're getting the liquid form, and it's probably worth trialing that before you go to the online sources. Online sources, you want reliable sources, so you can't always guarantee what's on the package. But the short answer is I think melatonin can do wonderful things in terms of sleep regulation. And if we're worried about giving kids Ritalin the next day to help their attention and focus, we should certainly, as a baseline, be making sure they get the best sleep they can, which is going to be far more effective than popping Ritalin in the next day.
I think we've only got one more question. We've got 8 seconds. What role do you see for an OT psychological therapy?
Certainly about regulation, their lifestyle. So diaries, set alarms, routines. It's mainly about dealing with their ADHD on a longer term basis.
Very practical, aren't they? If the education system was resourced better, would it decrease an emphasis on medication?
Yes, go Gonski.
could I ask where you get the Connors test information and access resources to use, please?
Yeah, I don't know. I haven't got a cheap source. So I write up my own question that someone with from the patent office would think looks very similar to a Connors, but I select a few questions and make it a quicker version. So I'm not sure about online sources, which I know are behind payment walls, and I don't know if anyone's got access to one that's not hidden behind a please purchase. So sorry, I don't have that resource.
I think this is going to have to be our last question. Which assessments can we offer to parents to take to teachers? I suppose that's if we're asking a teacher to do an assessment before they see you.
I don't know if you could do an assessment, but you could ask the teacher very focused. So I agree. It's fantastic to turn up to a referral just with any sort of information from the teacher straight away. They usually know what's happening if you mention that there's concern about possible ADHD. And most teachers will at least ask a colleague or be experienced themselves what sort of things they should be feeding back. But the main thing is to sort of go, I'm interested in feedback for the pediatrician or myself about focus, concentration, getting through tasks, maybe a degree of physical hyperactivity, but it's mainly those sort of more cognitive side and not so much about being poorly behaved. Because I think that's the main misconception I get back with, I try to get past with teacher feedback. And you get some fantastic feedback that you can pick the right adjectives that are in. So I don't think you need to be formal if you don't want to about the questionnaire. You can just say, please write down something, 2 paragraphs in writing so that the parent can take it away along, rather than the parent reporting what the teacher has said, which is, one step removed and not as reliable.
We've got one more question, and maybe it's just some local psychiatrists are referring adolescents to ADHD coaches in Melbourne. Yep. What's your view on this, on the coaches?
I don't know if I know enough about that to really make a comment. I imagine they are giving strategies for their life. So it depends on straight away what's the cost and the access. I imagine what a life coach is doing. It's all about know thyself. So certainly as the kids are getting older, I'm very keen that first of all we tell them what ADHD is. So they've often been diagnosed when they're 5 or 6, and no one may actually have sat down and said these things are really good about ADHDs, but this is the reason you find these things challenging. But I think it's a lot about framing your own life. So someone asked about the OT, and I imagine the coaching similar in terms of, okay, well, this is the way your body runs. This is the way your mind's built. How do you use it for advantage and avoid it holding you back? And things like keeping things structured, having a list for yourself, having alarms, being aware that, it's okay to sit in a meeting, but like I have my poppet here, so those things that we can do as we're adults and we become more self-regulated that we can't expect of a 6-year-old. So I imagine that's what ADHD coaches
I'm so sorry, but we have to finish. There's so much interest out there. So thank you so much for that. I think everyone's clapping at home, and we so appreciate you taking your time out this morning to talk to us, and hopefully we can work together. So thank you.
Thanks very much.
Thanks. So everyone leave and enter the next talk in 5 minutes. Thank you.